I see that got everyone's attention. That's better than a Hello Kitty clock. This legislative hearing of the Subcommittee on Health will now come to order. I'd like to welcome all the members and the witnesses to today's hearing. We look forward to a very productive discussion on some impactful veterans legislation. Today, we will discuss 10 bills ranging from improvements in the VA's implementation of community care to alternate paths for accessing care. Ensuring bureaucracy doesn't stand in the way of veterans accessing their earned health care has been an issue we have discussed at length this Congress. These bills include creative solutions to put veterans at the center of their own health care to meet their needs. I have heard stories from veterans in my district who live in rural areas and sometimes struggle to find appointments for care. Bureaucratic red tape should never be a barrier in veterans' health care. That's why I'm proud to support Chairman Boss to complete the Mission Act of 2024, which is on our agenda today. This bill would codify current healthcare access standards so that we can further support a veteran's right to seek care outside the VA if they're eligible. Community care is VA healthcare, and we continue to fight to make that message clear. This bill would also ensure that veterans have access to residential rehabilitation treatment programs for mental health and substance use disorders. These inpatient programs provide life-saving treatment that should not be withheld from veterans because of an unfair bureaucratic process. The other bills we are considering would make necessary changes to ensure veterans have informed choice in their health care. Access to health care should be non-negotiable, especially for our veteran population. Some of the bills before us today are a step in the right direction and will continue an important conversation about VA care. I want to thank our witnesses again for being here today and those organizations that submitted statements for the record. It is a privilege to collaborate on crafting impactful legislation for our veterans and to address critical issues in the delivery of their health care. I now yield to your Ranking Member Brownlee for any opening remarks she may have.
Thank you, Chairwoman Miller-Meeks, and thank you to our witnesses for being here today. I know we're all looking forward to a break for the holidays, being home with family, and I appreciate everyone making time to be here in the last week of session. I'm looking forward to discussing many of these bills. In particular, I'll start with my bill to learn more about VA's current approach to treatment and research on menopause. As more and more women veterans receive care at VA reach menopausal age, it will be more important than ever to ensure VA can provide the best care for them. I believe my bill, which directs GAO to report on the menopause care that VA currently provides, the research it is conducting, and potential areas for improvement will help do just that. I'm also looking forward to discussing Ranking Member Takano's bill to help address physician staffing shortages at VA by creating a scholarship program administered in partnership with the Uniformed Services University of the Health Sciences. Physicians who are trained through the scholarship program will graduate with military cultural competencies that allow them to better serve veterans, and through the program's service obligation, these physicians will spend part of their careers at the VA. I'm glad Ranking Member Takano can be here with us today to speak on his bill. I'd also like to mention Representative Landsman's bill to help improve VA's suicide prevention pilot and grant programs. VA has many programs to help address veteran suicide, but sometimes does not collect enough data to determine if the programs are working as intended. Representative Landsman's bill, the What Works for Preventing Veteran Suicide Act, will incorporate best practices for evaluating the effectiveness of VA's suicide prevention pilot and grant programs. And finally, I must note that I'm disappointed that half of the bills on the agenda seek to reduce VA's role furnishing and coordinating veterans care and expand eligibility for private sector care to the extent that it could potentially dismantle VA's direct care system. As we have discussed at countless hearings and events this Congress, including less than 2 weeks ago at an oversight hearing on VA's budget shortfall, more and more VA dollars are going to private sector care. Veterans are now receiving about 40% of their care outside the VA. I'm very concerned that many of these bills on this agenda would further open the doors to private sector care without regard for the long-term solvency of care provided in-house at VA facilities, which has been repeatedly proven to be superior in quality to the care veterans can receive in the community. While these bills purport to increase veterans' choice in where they access care, wait times for care in the community can be just as long or longer than those at VA. Without taking further steps to balance spending between private sector care and VA care, all we are doing is reneging on our solemn promise to ensure veterans get the best care available and passing the buck to private healthcare providers. Veterans do deserve a choice about where they receive care, but it must be a true choice and not a choice made for them by destroying VA's ability to provide veterans with timely, accessible, culturally competent, and well-resourced care. As always, I look forward to hearing the testimony of our witnesses on these bills. I hope we can find a path forward that achieves our shared goals of improving access to care for veterans. But we must always ensure we are upholding the integrity and stability of care provided at VA, and I expect that we will continue the conversation about these bills at a future legislative hearing during the 119th Congress. I thank you, and I yield back, Madam Chair.
Thank you, Ranking Member Brownlee. I'd like to acknowledge that we are honored to have the full chairman of the committee, Mike Boss, join us today. We have a full agenda, and I'll be holding everyone to 3 minutes per bill to ensure that we can move forward in a timely manner. This afternoon, we're joined by several of our colleagues who will testify on their bills. We appreciate their dedication to serving our nation's veterans. With that, I ask unanimous consent that all non-subcommittee members be waived on to speak on their bills on the dais. Hearing no objection, we will move forward. I now recognize Representative Bost for 3 minutes.
Thank you, Chairwoman Miller Meeks. You know, I recently introduced the Complete the Mission Act, which would take VA health care more available for all veterans. Far too often, I still hear veterans from around the country telling me stories about how long VA wait times are. I hear from other veterans about their community care refusals being denied or refused and denied. Community care is VA care. I have said it again and again. When we passed the Mission Act in 2018, we expanded VA health care for veterans to get them the care that works for them, where it works for them, and when it works for them. The law is not optional. My bill would build on the Mission Act by ensuring that bureaucracy doesn't get in the way and VA care is accessible to every eligible veteran. Veterans should be able to make their own informed health care decisions just like every other American. My bill would codify the access standards for community care to make that perfectly clear. We must remember, and you've heard me say it time and time again, the VA was not created for the VA. The VA was created for the veteran. These standards were established by the VA and give veterans clear measures for their community care eligibility. My bill would also create a process for veterans to receive mental health treatment for substance abuse at a community-based residential program. There should be no wrong door when it comes to combating addiction. We must ensure that veterans who are struggling with addiction have every option available to them to get treatment that they need. It should go without saying that we have a responsibility to ensure veterans have access to VA care they are eligible for in a timely manner. And I look forward to discussions on my bill today. Thank you, and I yield back.
Thank you, Chairman Boss. I now recognize Representative or Ranking Member of the full committee, Representative Takano.
Thank you, Chairwoman Miller Meeks and Ranking Member Brownlee, for the opportunity to speak in support of my bill, H.R. 10381, the Supporting Medical Students and VA Workforce Act, which I am pleased to co-lead with Congressman Neil Dunn of Florida. This bipartisan legislation will allow VA to take a step forward in addressing physician staffing shortages. VA clinicians deliver high-quality health care specific to veterans' needs at more than 1,100 hospitals and outpatient clinics nationwide. As more and more veterans access care through VA, Congress must ensure VA has enough staff to meet the increasing demand. Our veterans deserve nothing less. This bill would create a scholarship program through which VA would pay for individuals to attend medical school at the Uniformed Services University of the Health Sciences. These individuals would be commissioned as junior officers of the U.S. Public Health Service Corps and receive a world-class medical education that includes unique military-specific instruction. In exchange, following completion of their residencies, recipients of these scholarships will serve as VA physicians for up to 10 years to fulfill their public health service obligation. Now, VA faces persistent staffing shortages and difficulties with clinician recruitment and retention, particularly in rural areas. The Supporting Medical Students and VA Workforce Act would allow VA to address these challenges while also helping to educate the next generation of public health professionals. This bill creates a direct pipeline for talented, mission-focused clinicians with military cultural competencies to begin their careers at VA. These newly trained physicians will be deployable to rural or underserved VA medical facilities. The hope is that at the end of their period of obligated service, these clinicians will choose to continue their careers at VA, and after just 10 years of operation, VA estimates that this program would reduce VA's national physician shortage of over 1,000 physicians by 33%. Now, I'm proud this bill has the support of VA and many veteran service organizations, including the American Legion, Veterans of Foreign Wars, Disabled American Veterans, and Paralyzed Veterans of America. This bill is also supported by other organizations, including the American Federation of Government Employees, the Veterans Healthcare Policy Institute, and the National Association of VA Physicians and Dentists, and others who all understand that we must do more to provide VA with the necessary tools to hire and retain highly skilled clinicians to care for our veterans. I'm thankful for Congressman Dunn's partnership on this important legislation and look forward to working with Congresswoman Miller Meeks, Chairwoman Miller Meeks, Ranking Member Brownlee, and Chairman Bost and the full committee to advance this bill next Congress, and I yield back.
Thank you, Representative Takano. The chair now recognizes Representative Mast for 5 minutes on his bill, 8481.
Thank you, Chairwoman. I thank the whole of the Veterans Affairs Committee for hearing me. I appreciate the opportunity to speak today on my bill, H.R. 8481, the Emergency Community Care Notification Time Adjustment Act of 2024. That was a really long name that one of my staff came up with. But under current VA law, what happens is if a veteran seeks emergency care outside of the VA system, they are required to notify the Department of Veterans Affairs within 72 hours of admission into the hospital so the Veterans Health Administration can cover the costs of that care. And I don't know how many of you have been admitted into the hospital in serious ways, but when you're looking at those bureaucratic requirements and the fact that an individual may be incapacitated or they may be just out of surgery, they may be drugged up on medications that they've never been on in their life. There's a lot going on in their mind that may not have them thinking about, have they notified the VA within 72 hours of when they came into that facility? In many cases, you may not have any idea how long you've been in that facility. You've come out of anesthesia. There's a host of things that put you into a state of some level of confusion. In some cases, a veteran, they may not have family that are there to support them. So in my mind, that is not a fair expectation to put on a veteran or the family members. So my legislation would make a very simple change. Instead of requiring the veteran to notify the VA within 72 hours of admission, my bill would delay the notification deadline to 72 hours after the veteran has been discharged from that hospital. The legislation cuts the bureaucratic red tape that leads to veterans being penalized and having to pay potentially thousands of dollars for something that is out of their control, the very situation that actually inspired this legislation. I had a constituent came to my office for assistance, very serious help. Her husband passed away just days after being admitted to a non-VA facility. She missed the deadline for notification and was sent with a medical bill of over $100,000. That is wrong. By providing veterans and their families more time to notify the VA, we allow the veteran to prioritize their health and their recovery above administrative requirements. That is why I'm passionate about seeing this bill pass, and I'm grateful for the opportunity to be here today to testify on this legislation. And in closing, I would just, again, like to thank my colleagues on both sides of the aisle who have supported this effort, and for the veterans organizations who have endorsed this legislation, including the American Legion, the Disabled American Veterans, DAV as we call them, and the veteran service organizations in my community of Palm Beach County and Martin County, Florida, those that we've worked on with this. And with that, I thank you, Chairwoman, and I yield the remainder of my time.
Thank you very much, Representative Mass. The chair now recognizes Representative Landsman for 5 minutes to speak on his bill, H.R. 9924.
Thank you, Madam Chairwoman, and thank you to the ranking member. So the bill that we introduced is a bipartisan effort, the What Works for Preventing Veteran Suicide Act. I do want to thank the subcommittee for hosting this legislative hearing and for the opportunity to discuss this really important piece of legislation. Again, the title is What Works for Preventing Veteran Suicide. It's been a pleasure working in a bipartisan coalition with my colleagues, Representative DeLuzio, Van Orden, Luttrell, to show our commitment to focusing on proven strategies that save lives. Every day, on average, about 17 veterans take their own lives. It's obviously an alarmingly high number. But one would be an alarmingly high number. These are folks who have served our country, and we owe them everything in return, and certainly the best care possible in their times of need. We spend hundreds of millions of dollars through the VA to prevent suicides. And some of that works and some of that doesn't work. And what we're trying to do with this bill is get the data and the assessments that would be helpful in determining what is working, what's not working, and how do we improve, so that every dollar that we're spending goes to those things that are having a real impact on improving outcomes for veterans who are really struggling. The bill would require the VA to develop best practices for suicide prevention programming, making sure prevention efforts are smarter, more effective, and shared across all organizations inside the VA and outside the VA involved in helping veterans. By focusing on what works, the VA can direct resources to proven strategies, helping to prevent more veteran suicides, keeping more and more of our veterans here with us. The bill won't increase costs to taxpayers, and instead it will ensure taxpayer dollars are being used effectively and efficiently. Last year we introduced and stood up the What Works Caucus, a bipartisan caucus with a mission to ensure our tax dollars are being spent on those things that are working. It is a bipartisan caucus. Those of you who are not part of it are welcome to join. This was one of the first bills that they endorsed. And we hope that this passes and becomes law. And with that, thank you, and I yield back.
Thank you, Representative Landsman. The chair now recognizes Representative Roy for 5 minutes to speak on his bill, H.R. 5287.
Thank you, Madam Chair. Thank you and the ranking member for having us here today. It's good to be back in the committee. I miss it. I was silly enough to go over to the Rules Committee and no longer on this committee, but it's a great place, and appreciate the time to be here. I am here to talk about H.R. 5287, what we call the Veterans Access to Direct Primary Care Act. This bill is one of the first bills that I introduced when I was a fresh member of Congress in the 116th Congress. I had heard a lot from veterans in the district I represent, which is Austin, San Antonio. There's a very, very large veteran population, obviously large active duty population because of San Antonio, but as a result, I've got, and one of the first things I did when I was elected was create a Veterans Advisory Committee and take in input from them, and this was one of the first things that they talked about was running into the wall of bureaucracy is a loaded term. It's be a slight at the VA, but we all recognize the truth and the reality of what a lot of our veterans run into. So they were complaining about that, and at the time, DPC, direct primary care, has been a growing alternative out there in the healthcare world. it's something that I'm championing in the private sector space as well, to be able to give people, because it's gotten kind of like lumped off into this, oh, well, that's concierge and that's for wealthy people. And that's just not true. One of the best DPC clinics I went to was actually in East Austin, where some guys had set up stuff for basically artists and kind of your underserved community in East Austin, particularly in the arts community and music community and so forth. And the success they were having, and be able to let people come for cash pay services and keep prices down that aren't inflated by insurance companies and by government bureaucracy. So the purpose of this bill is to create a 5-year pilot program to the Center for Innovation that was established in the Mission Act. And the purpose is to develop innovative approaches to testing, payment, and service delivery models. So what we want to do is do that. Direct primary care is now being used by 300,000 Americans in the private sector space, and frankly growing quickly. And so we'd like to be able to have this legislation move to be able to create this model and a pilot for the VA to try to set this up in a model where it'd be a health savings account that veterans would be able to use and go out and find a doctor that isn't operating just under the very complex insurance-constrained healthcare environment. So that's the goal of the bill. That's the goal of the legislation. I can get into greater detail, but y'all can read the bill and look at it, and you're gonna. I'm happy to make myself available anytime, but I think it's an important piece of legislation, and I think, and again, this falls into that thing that I think shouldn't necessarily be partisan. We ought to all want to figure out how to streamline and cut through the bureaucracy of both government and, frankly, increasingly insurance companies. Insurance companies, let's be honest, they're a part of the problem, and we're going to have to figure out how to break that down, and then the VA is a part of that as well. So appreciate the time. Thank you, Madam Chair.
Thank you very much, Representative Roy. We have, for those off-committee members, you may remain around to ask our witness questions if you have time or if you wish so. As is our practice, we'll forego a round of questioning for the members. We do have several members on their way here to speak on bills, but I think what I'd like to do is go ahead and invite our first panel to the table, and while they come up to the table, if these other members come, we will then revert back to having them introduce their bills. So if the first panel will come to the table, thank you. Thank you very much. Joining us today from the Department of Veterans Affairs is Ms. Hillary Peabody, the Acting Assistant Undersecretary for Health for Integrated Veteran Care. She is accompanied by Dr. Erica Scavella, the Assistant Undersecretary for Health for Clinical Services. Ms. Peabody, you're now recognized for 5 minutes to present the department's testimony.
Chairwoman Miller Meeks, Ranking Member Brownlee, and other members of the subcommittee, thank you for inviting us here today to discuss several bills concerning VA. Joining me today is Dr. Erica Scavella, Assistant Undersecretary for Health for Clinical Services. In reviewing the legislation before the subcommittee, we saw a recurring theme: proposals that would reduce VA's role in providing and coordinating care for veterans. We fundamentally disagree with this approach. What I believe we can agree on is that our nation's heroes deserve access to high-value care where they need it, when they need it. This past year, VA achieved a historic milestone by delivering more care for more veterans than ever before, thanks in part to the bipartisan PACT Act. VA completed more than 131 million healthcare appointments, a 9% increase over last year, all while reducing primary care and mental health wait times. Additionally, 70% of VA hospitals earned 4 or 5 stars on CMS's hospital quality star ratings, compared to 41% of non-VA hospitals. Independent data consistently show that veterans who receive care through VA experience better outcomes and higher satisfaction compared to veterans who do not. This level of excellence reflects the veteran-centric care that we all agree veterans have earned. VA's integrated care model is designed to address veterans' unique needs, ensuring continuity of care and offering a deep understanding of challenges faced by those who've served. It's why we have such impressive outcomes and why veterans trust VA so much, now at an unprecedented rate of 92% in our most recent healthcare trust scores. And just this last month, I saw that was already at over 93%. A few months ago, I met Army veteran Star McMorris when I was at the William Bill Kling Outpatient Clinic in Miami. She told me VA was a lifeline for managing her depression. After her military service, Star said she was mentally, spiritually, and physically depleted. It took seeking treatment at VA to change the course of her life, and she said she's not looked back since. In fact, Star now works as a peer support specialist, helping other veterans in Miami's Psychosocial Rehabilitation and Recovery Center. Reducing VA's essential role, as proposed in many of these bills, risks undermining our ability to serve veterans like Star McMorris and the veterans that she supports. Bottom line, we share the committee's dedication to getting veterans the world-class care they deserve, and we have significant concerns about the methods proposed in some of the bills that we'll discuss today. Several provisions risk diverting resources from programs that veterans rely on. Though these proposals aim to increase choice, they may end up reducing it by eroding VA's ability to provide specialized, evidence-based care. Chairwoman Miller Meeks and Ranking Member Brownlee, VA is committed to working with Congress to safeguard and enhance care for our nation's veterans. We appreciate the opportunity to speak with you today about how we can accomplish that, and we look forward to answering your questions.
Thank you very much, Ms. Peabody, for your testimony. I'm now going to recognize Representative Malloy to speak on her bill 112. The other members that are on their way will have to wait until we start our line of questioning.
Thank you, Madam Chair. H.R. 10012, the C Act, came about because I had a constituent in rural southern Utah who couldn't get to Salt Lake City to get his glasses. It was a 500-mile round trip. So he can see a local eye doctor to get an eye exam, but he can't get his glasses fitted in southern Utah. So in order to actually get his glasses, the VA will pay for mileage for him to drive to Salt Lake. They'll pay for a room for him to stay in Salt Lake, but they won't pay for him to go to a local eye doctor, get his glasses. It doesn't make a whole lot of sense, and my concern is that people in my district, most of which is very rural, are just going to not get eyeglasses because of bureaucratic rules that might make sense in a manual or on paper, but they don't make sense for veterans who need eyeglasses to be able to see. And I see from my notes here that the VA doesn't support this bill, so I would ask you to reconsider that and to work with my team, and let's find ways to give good service to the people who've served our country and are now, we owe them good health care. They want good health care, but they don't all live in Salt Lake City or in urban areas close to a VA hospital. And with that, Madam Chair, I will yield back. I'm sorry I was tardy.
Thank you very much, Representative Malloy. The chair now recognizes Representative Stubbe to speak on his bill, H.R. 214.
Thank you, Madam
5
Chair.
minutes.
And thank you for the opportunity to address the committee today. I've worked on this piece of legislation for years, and it's an honor to have the opportunity to explain it to you. My bill is the Veterans True Choice Act, which would give veterans true choice in their health care decisions. Time and time again, the VA has failed to meet the health care needs of our nation's veterans. Reports of neglect and outright malpractice by the VA have resulted in unnecessary suffering for our veterans. Far too often, veterans in my district contact me to share shocking and horrifying accounts of their experiences seeking care at VA facilities. Last year, a veteran in my district lost his eyesight in his right eye because the VA refused his community care until it was too late. His community care ophthalmologist even told him that he had come in just a month earlier, his vision could have been saved. The VA's negligence is literally blinding veterans, emblematic of a system drowning in bureaucracy and malfeasance. Even worse, mental health care has been an outright disaster in the VA. Veterans in crisis are succumbing to their own despair because the VA fails to provide timely and effective mental health care when veterans need it the most. Attempts to improve the VA's mental health care have been insufficient to make any lasting improvements for the systematic mental health crises impacting veterans nationwide. Veterans are tired of the endless barrage of excuses and inaction, and we owe it to our nation's veterans to ensure they receive the care they rightfully deserve. Veterans who've sacrificed for their country earned and deserve top quality medical care that meets their unique needs. It's time we give veterans true choice in accessing health care that works best for them. My bill would accomplish just that by empowering service-connected disabled veterans with the ability to continue receiving care through the VA, or allow them to access patient private health care providers through TRICARE Select and TRICARE for Life. This VA and DoD partnership will improve VA's ability to help veterans select the health care program that is right for their health care needs. And in a district like mine, I don't have a VA hospital in my district, so veterans have to travel hours to get anything more than primary care, and those hours can be impactful in someone's health care. So giving somebody true choice and the ability to have TRICARE to go in the community that they have to get the health care they need when they need it, I think would be tremendous. To give you an example, the hospital that I would have to go to if I do utilize the VA for health care, the hospital that is assigned to me is called Bay Pines. Bay Pines has a 1-star rating by the CMS. So our own government, CMS, is rating that hospital as a failing hospital. The hospital down the road, 20 minutes from my house, is a 5-star rated hospital. Sarasota Memorial Hospital has a trauma center and all of that. So giving veterans the ability to use TRICARE to go where they need to go, when they need to go, I think will save billions of dollars and give healthcare outcomes to our veterans that are much better than what we have today. This bill isn't about dismantling the VA, because that's not what it would do. It's about giving every service-connected disabled veteran access to the highest quality care they are so rightfully due. It's time to put veterans first and give them a true choice to find care that best meets their needs. And I yield back.
Thank you, Representative Stubbe. As is my practice, I'll reserve my time until all other members have had a chance to ask their questions. I now recognize Ranking Member Brownlee for 5 minutes for any questions she may have.
Thank you, Madam Chair. Ms. Peabody, thank you for being here. One provision of Chairman Bose's bill, the Complete the Mission Act, codifies VA's existing community care designated access standards and bars VA telehealth appointments from being factored into veterans' community care eligibility. I'm referring to the wait time and drive time standards that make veterans eligible for referrals to private sector providers if a VA appointment isn't accessible. Could you elaborate on why VA opposes Section 101 of Mr. Boss's bill, and how do wait times outside of VA compare to those within VA facilities?
Thank you for that question, Ranking Member. VA does not believe that it's necessary to codify our existing regulatory access standards. We believe that such an action would limit our ability to adjust to market forces that that impact access and require Congress to change the law whenever such a change is warranted. So we'd like the flexibility to be able to make changes to match industry best practices and meet veterans' needs. To address your question about wait times, in general, our wait times within VA are significantly faster than what we see in the community, and that includes both veterans who get care through our community care program, as well as veterans who access care through another mechanism, like through their own insurance. We publish our wait time data on the Access to Care website on www.accesstocare.va.gov. And that really is there to make sure that veterans and their family members can make informed choices about their health care. While there's no apples-to-apples comparison of how we can look at our wait times within VA and in the community, what we've seen just looking at fiscal year 2024 data, for example, in primary care, we had an average wait time of 24 days compared to 55 days in the community, and that's just for new patients. For established patients across primary care, mental health, and specialty care, our wait times were between 5 and 9 days, and that's about 95% of our consults. For mental health, we had an average wait time of about 20 days within VA, and in the community, that was 39 days. And in specialty care, our average wait times were about 32 days compared to 44 days in the community. And there's several industry studies that point out some of the challenges the industry has across a number of specialties, primary care and mental health, that will show similar high wait times.
Thank you for that. Another question I had for you this morning, VA's Office of Inspector General issued this fraud alert announcing that it is investigating allegations that certain drug and alcohol rehabilitation facilities are attempting to exploit veterans for profit through various unethical and illegal practices. Do you share these IG's concerns?
Yes, we share those concerns, and we are actively working with the IG on a number of investigations.
And have you seen for yourself, or the VA has seen for itself, some evidence of this in VA's community care program at all?
Thank you for that question. We are working in collaboration with the IG on several open investigations, and so we'll continue to partner with them as well as with our third-party administrators.
Very good. I know in Mr. Boss's, Chairman Boss's bill, he increases the number of veterans receiving substance use treatment from private sector providers. Do you know, I don't know offhand, but do you know if his bill includes any safeguards that would keep scammers like the ones the IG is investigating out of the program?
I'd like to hand that to Dr. Scavella.
Yes, so thank you for that question. I'd actually have to study the contents of his bill to make sure that all of those types of concerns are included. We would want to make sure that veterans are being appropriately screened and brought into health care to make sure that it's appropriate. We have, and Ms. Peabody has experienced, some concerns with some self-referrals and some predatory organizations that have taken advantage of our veterans.
So I don't have much time left, but I do want to point this out, is that VA's rate of spending on emergency care has increased steeply since 2020, when the department decided to start processing the majority of emergency care claims under the same payment authority that applies to non-emergency use, is my understanding. VA is now spending about $8 billion a year on these claims, and while I certainly support VA being the primary payer on claims related to veterans' service-connected disabilities, I think we need to take a closer look on how VA covers emergency care claims that are unrelated to service connection conditions. I think we need to be as responsive in those situations. But would you agree with that, and do you think we need to dig deeper for better solutions?
Thank you for that question. We do agree that the current legislative authorities that we have, as well as any administrative actions that we could take to streamline, would be a bit of a patchwork quilt, so to speak. And so we're very open to talking with the committee staff about how we could streamline some of our emergency care authorities.
Thank you, and I yield back, Madam Chair.
Thank you, Representative Brownlee. The chair now recognizes Representative Murphy for 5 minutes for any questions he may have.
Thank you, Madam Chair, and thank you, guys, for convening this meeting. I appreciate the charge of our VA is to take care of all our veterans and be that safety net, be there for everything. However, I just have to push back on the maligning of community care. I'm actually one of those people that has done it for 30 years, and there are two things that I think we just need to understand and agree upon. Number one is community care essentially is specialty care that the VA cannot offer. That's primarily what it is. And specialty care, by its definition, is more expensive because, guess what? Those are specialists. And they oftentimes need surgical intervention, which, guess what, is more expensive. And so just, maligning community care just because it's more expensive, you have to understand why it's more expensive. It tends to be specialty care. I'm a specialist, I'm a surgeon, I'm a specialist. It costs more when you operate on those things. The other thing is wait time. Wait time for primary care out in the community can be long now, but it's even exacerbated now because we have too few specialists in this country. So yes, wait time is longer, but it's because they are specialists. So again, when we're making this discussion, and I hate that it's a pro-con thing because I worked as best as I could always to provide our veterans with the best care. The problem is the VA never followed up. We were never sent records. We were never sent anything. It's a big black box. So it's much more difficult to take care of veterans in the community because the VA doesn't want you to. And I can understand that to a point where you're trying to provide a body of care, but the fact that the VA will sometimes just literally not cooperate at all hurts the veterans. So I think that's important. I think another thing I think that needs to be brought out is Dr. Anal had said earlier they're working on trying to get inefficiency and productivity within the VA system. If a VA doctor sees 7 patients a day when the community would see 25 or 30, that's an issue. So that's an issue within the VA that the VA needs to take care of itself. So just like many of the members of this community, on this committee, I have a ton of it. 1 out of 10 of my constituents is a veteran, and we hear the complaints. So what am I supposed to say to all our veterans who are unsatisfied with the system? That 92%, that's great. That's not what I see. And so if a veteran is referred out or doesn't get into the VA in a correct period of time, what am I supposed to say to them, Ms. Peabody? I mean, there's only so many calls and so many times that we would reach out to say, hey, can you get this person in, et cetera. What am I supposed to say that? Because please don't paint this as a beautiful picture, because it's not. That's not what we hear from our constituents.
Thank you. I'd like to turn that to Dr. Scavella.
Yeah, so thank you for that question. So you raised several concerns that we are working to address. So we are very pleased that in some areas we have done a great deal to improve quality and access to our veterans, but we do recognize that there are pockets in our system where we do need to make improvements. So you raised several concerns. One, we actually do have just under 100,000 veterans who are actually getting primary care in the local community, and I do recognize it as a specialty since I'm an internist. So that is a portion of what we're providing, but you're correct in that for specialty care, for subspecialty care, for surgical care, that is more expensive and the wait times are longer. So we do recognize that, and we are working to try to address that both internally.
Nothing need to address, it's just a fact. And so when you malign the community care and saying, well, you have longer wait times, well, it's because everybody has longer wait times to see a specialist. That's all. I just want the vocabulary to be fair. That's all.
We understand that. I take that at full face value. The other thing is we do have an interoperability pledge to try to work on the issue with the medical records. Having worked in our system, taking care of veterans myself, and having patients who chose to go to community physicians such as yourself, and I was tracking down the records. I understand what that is like. So our Undersecretary for Health has entered into an agreement with 13 healthcare organizations to make sure that we are able to get those records back in a timely fashion. So we'll have those, and also to share our records with you so that we'll be able to provide that timely care. And then the third concern you've raised about pockets where we're not being as efficient and as productive. We are addressing those issues, and we definitely want to make sure that we don't have clinicians that are seeing small numbers of patients where others are seeing many large numbers.
And I appreciate that. Again, we won't go back to the whole debacle, I think, of the VA's choice of electronic medical records, because I can't access any of that stuff. If they were on another system, I can access that. And I don't know how many times in the last 30 years I've had a veteran show up extremely disappointed because they got referred to me, but there were no records ever there, and I have to literally send them back to the VA when they have a cancer diagnosis. Go back, get your records, which is frustrating for me, but also infinitely frustrating for the patient, because then they got to get another appointment, et cetera, et cetera. That's something that the VA needs to be much better about. And if the VA is going to refer somebody, it should be a pledge, it should be a requirement that the records that that patient goes with are handed to that VA patient before they leave, period. Because I can't count on them coming to me. So thank you for that, Mr. Chairman. I'll get back.
Thank you, Representative Dr. Murphy. The chair now recognizes Representative Luttrell for 5 minutes for any questions you may have.
Thank you, Madam Chairwoman. Good morning to both of you. Thank you for joining us today. In your opening statement, you listed a bunch of successes, which I'm going to piggyback off what Mr. Murphy was just speaking on. The successes are great, and I applaud the efforts of the VA to get those. Make no mistake about it, we hear from our constituents and myself and the rest of the committee members, we visit all of our VAs in our districts, in our states, and nationally. And the problems that I have, and I'm a very rural area too, so my veterans have to travel. And to Ms. Malloy's statement, if you're going to have a veteran traveling 490 miles to get a set of eyeglasses because community care refuses, the VA refuses to assist that veteran in community care, that's a big deal. Something that needs to be directly addressed. Now, in H.R. 1639, I'm going to talk to you, Ms. Peabody, Ms. Scavella, you may be the one that's going to jump on top of this, the VA's Zero Suicide Demonstration Project Act, which the VA opposes. Now, The VA opposes it. It says VA does not support this current bill for clinical, fiscal, empirical, contractual, and technical and empirical reasons, which are elaborated in the following responses from the VA. How many veterans did we lose last year from suicide?
Yeah, so thank you for that question. And obviously, we are committed to ensuring that we are providing the best possible care. That number is going to be forthcoming in our annual report, which is going to be released this week.
Last year, not this year. How many last year did we lose?
I don't have the number in front of me.
Over
so
4,000.
Yeah. So
You know how many was the year before that? Over 4,000.
Correct.
In the past, I'll just throw this out to you. I need to get the exact number. And I would say in the past decades, when Congress gives the VA money for suicide prevention, to take that number completely down to zero, the number of suicides over the past 50 years plus has increased. So when I read the reason that the VA opposes 1639, the VA has the same problem. So I take offense to the VA saying that what we're trying to do to decrease that number, you have a problem with. Because I have a problem with the VA. You're failing when it comes to preventing veterans from committing suicide. The number is growing, continuing to grow. So I don't want you to sit in front of me and tell me that we're having a bad idea when you have no idea whatsoever. Now, you sitting in front of me and say, oh, I'm going to wire brush you for this, okay? And you can go back to yell at whoever you want. But as hard as we're working to try to fix this problem, don't present to us the same problems that the VA has and not give us a better answer than that. Please respond.
yes, so we do have answers to that. So in response to Landsman's proposal for some additional studies, our concerns with that particular piece of legislation is that we do have ongoing work that's coming out of the Hannon Act and the legislation there, and we're providing reports that are indicating exactly what we're finding related to suicide prevention. We're using our annual reports to really dive down on what we're seeing. We recognized a trend with women veterans using lethal forms of weapons, and we've addressed that, and we've reduced lethal means suicides in women veterans significantly to less. We've reduced it by over 45%. We've looked at
okay, so you reduced, but in the men's side is.
And
Make no mistake about it, and I respect Ms. Brownlee's efforts on our women veterans, but at the end of the day, we're all veterans.
Correct.
We all wear that uniform, so if you're specifically focusing on just trying to get the women's suicide rate down, that's great.
That's not the case, sir.
Okay,
with all due respect, we are working on improving the numbers for all different demographics. For men, unfortunately, compared to the United States, the suicide completion rate of non-veterans amongst men is increasing, but we've seen a smaller increase amongst men. We've also looked at different demographics. We've seen a reduction in suicides amongst men and women between the ages of 18 and 34.
You said you've seen a reduction?
Yes.
That didn't populate in the numbers last year.
We're looking at the current data that we're releasing our report this year.
So the current data is going to show this year
our numbers
that the suicide rate is down. That's what you're telling me?
Our numbers are concerning. I'm not saying that they're not, but we are making inroads based on the annual report and actually diving deeply into each section to determine where we need to make inroads. So we're looking at all different types of demographics. We're looking at other types of social determinants, including housing stability, other mental health diagnoses, and all those things factor into the care that we're providing.
And through the results of the studies that you're conducting, you're going to write up a piece of legislation that you're going to present to Congress that says this is the way forward to reduce suicides to zero?
Actually, what we're recommending is that we have legislation in place that looks like it is working, but we're within 18 months of the first report, and we're looking at providing a final report in September 2025. And we would like to continue to delve deeply into what we're doing and use existing authorities to make sure that we're not unintentionally either harming veterans or their communities by stopping things that seem to be working. So we would like the opportunity to continue to work with this body to determine what continues to make sense. But we're early into this journey. The Hannon Act was just recently enacted. We've got grant programs taking place, the Sergeant Fox grant program, which is making a difference, and we're seeing different improvements in different areas, and we'd like to continue that. I do share your concern, though, that we still are seeing suicides that are being
all right, so I can't wait to see the results of your studies than what the numbers produce for 2024. And I hope you're right.
Yeah, our report, we've given an interval report in November of 2024 that.
I'm going to cut you up. Sorry. I'll meet you after class if you don't mind. Thank you. Sorry, Madam Chairwoman. Apologize.
The gentleman's time has expired. The chair now recognizes Representative Budinsky for 5 minutes for any questions she may have.
Thank you, Madam Chair. Thank you, Madam Ranking Member. Dr. Scavello, we share a deep concern about how several of the bills on today's agenda have the potential to severely undermine the VA's ability to provide care to veterans. VHA has other missions beyond being a direct provider of care, right?
Correct.
How will diminishing resources for VHA's direct care system in favor of privatization of veterans' health care affect VHA's other three missions, research, training, and emergency response?
Yeah, so thank you for that question. So we do have 4 missions within VA. The first is obviously to provide health care. The second is related to our training mission for healthcare professions trainees, which includes our physicians, our nurses, and our other allied health professionals. We also have a research commitment, as well as supporting the United States in times of public health emergencies such as COVID. So what we're seeing is, as a result of not having the number of cases, the complexity of cases within our building, is that we're unable to retain, also recruit the staff that's required to work in those areas. That has a trickle-down effect to our ability to conduct research, our ability to continue to partner with medical schools and nursing schools to bring students in, which thereby will continue to further reduce the talent that we have available within VA, and unfortunately, also in this country, because 70% of physicians do come through some type of VA experience during their either medical school or residency training. So we know that there's a trickle-down effect. So that is concerning to us.
Yeah, and that was actually going to be my follow-up, is how, could you speak a little bit more to how that can impact then the overall healthcare system?
Yes.
Yeah.
So with those training opportunities, again, through all of those different professionals, including clinical pharmacists, we're concerned that without having the rigor of the cases, that's going to potentially affect the ability to provide that training and education to the country's healthcare professionals. There was a saying when I was a resident, I used to take call-up between every 2 to 4 nights, overnight, in a house. And the common statement by our attending physicians when I was a resident was that if you are off every other day, you miss 50% of the cases. If we don't have the cases coming in our doors, then our residents and our trainees are missing those cases and can't build their skills, can't build the momentum to advance.
Thank you very much, and I'll yield back my time.
Thank you very much, Representative Budinsky. The chair now recognizes Representative Radewagen for 5 minutes for any questions she may have.
Okay. Towel for Madam Chairwoman. My question is for Ms. Peabody. Your written testimony states that VA opposes codifying access standards for community care. Why do you think unelected bureaucrats, rather than elected officials, should determine when veterans should have choice in their health care decisions?
Thank you for that question, Congresswoman. We're focused on providing veterans access to world-class care that they deserve, where they need it and when they need it. And healthcare is an ever-changing landscape. And so we think it's very important that the department has the flexibility to be able to adapt with changes to the industry. We're not comfortable with the overly prescriptive proposal in the legislation. We feel that codifying it would inhibit our ability to make sure that we can best serve our veterans. And we're happy to discuss opportunities for improving the legislation.
Ms. Peabody, is telehealth being pushed by VA to reduce veterans' community care eligibility?
I'll take that question. So telehealth is not used as a modality to stop the care that's provided in any modality. Between a clinician and a patient, there's discussion about the appropriate type of care that should take place. If telehealth is a viable and safe and high-quality solution, then we'll recommend that. But we also look at telehealth opportunities in the community as well as within our organization. And what we don't want to do is deny somebody a face-to-face visit in the community if the same care can be completed via telehealth internally and vice versa. So again, ultimately it's the veteran's choice what they're comfortable with, and it also depends on the clinical situation we're treating. If the situation is amenable to telehealth and that's the most accessible form of healthcare, we will provide that and offer that as an option.
Thank you, Madam Chairwoman. Yield back.
Thank you very much, Representative Radowagen. The chair now recognizes Representative Rosendale for 5 minutes for any questions he may have.
Thank you very much, Madam Chair, and thank you for holding this hearing today. I look forward to discussing many essential pieces of legislation that I'm proud co-sponsor of that have been brought in. My job is to ensure that veterans receive top quality health care they have earned, whether at the VA or through care in the community. My job is not to protect the VA, and it certainly is not to protect the American Federation of Government Employees. I've heard you say time and time again that the veterans should be receiving the care that they have earned. Yeah, they deserve it, but they have earned. This is a contractual agreement, when they want it, where they want it. But then you sit there and oppose the very legislation that is going to help us deliver it. One of President Trump's achievements was the passage of the VA Mission Act. The legislation gave veterans a true choice by establishing a permanent program to provide hospital care, medical services, and extended care services to veterans through the non-VA healthcare providers. The Mission Act is necessary as many rural veterans live hundreds of miles from VA facilities, and others must wait months to get the care at VA facilities. Our country owes a debt of gratitude to our nation's veterans, and the least we can do is have a health care system that provides access, and I will say, when they want it, where they want it. The Biden administration has been trying to kill the VA Mission Act by not paying providers in a timely fashion, forcing them to drop out of the program, canceling veterans' appointments, and denying community care referrals, waiving wait time access standards, and not even informing veterans about the community care program. The problem is that if the criteria for allowing veterans to easily access community care is not codified, you say you need that flexibility. But the problem is that if it is not codified, the VA has already demonstrated their ability and their desire to deny that coverage. You've been very misleading about making sure that the veterans can access it. Ms. Peabody, the VA opposes the Veterans Health Care Freedom Act, correct?
Correct, sir.
Why should veterans not be able to choose where they receive their health care?
Thank you for that question. VA is supportive of veterans being able to provide input into where they get who their provider is.
Where they want it, when they want it. That was your words. That's the words I've been using for the last 4 years as I've sat on this committee. Where they want it, when they want it. Why should veterans not be able to choose where they receive their health care?
Thank you for that question. So
do they have the ability, as you say, to choose where they want their health care, when they want their health care, or do they not?
So my words were where they need it, when they need it.
Oh, so you know better what they actually need than the veteran themselves. Let me tell you, in an urban area, in an urban setting, it is very easy for the veterans to travel to a VA facility. Very easy. But in states like Montana that take 12 hours to drive across the state, it just doesn't make sense, not financially or from a delivery standpoint, to try and build the VA facilities around the state that are going to give that same type of access, okay, to the veterans that are in the rural communities that they have in the urban areas. They are not going to have that. So they should be able to access that health care in their own community. And you don't know better than that veteran. You don't know better than that veteran. They know what they need, and they know when they need it. Yes or no, do you think the VA is more equipped to choose where a veteran receives the health care than the veteran themselves?
Thank you for that question. It's very important that a clinician is able to determine that there is a clinical need for the care, but absolutely in compliance with the Mission Act, we if a veteran would like to get their care through the community, we will assess based on the eligibility criteria, including the access standards.
Well,
to make that
again, what
determination.
we have seen, this committee and the community of medical providers, is that the Veterans Administration has the desire and the ability to deny that coverage and to keep the veterans from accessing their health care when they want it, where they want it, in an attempt to try and drive all of the veteran care to the VA facilities, and that is not in the veterans' best interest. Thank you, Madam Chair. I yield back.
Thank you, Representative Rosendale. The chair now recognizes Representative Malloy for 5 minutes for any questions she may have.
Thank you, Madam Chair. I just want to maybe pile on what Mr. Rosendale's been saying, but I introduced the C Act to try to help veterans in rural areas get their eyeglasses, and the way it's working right now isn't convenient for the veterans. It's also not saving tax dollars. It seems like we should have one or the other, but it's more expensive to send someone from a rural area to an urban area to get their glasses, and it's also less convenient for the veteran. The notes I got back from the VA on this are that the VA doesn't support this bill because it's not necessary for the intended outcome, and the VA could do this under the current authority. But the VA hasn't done it under the current authority. And then later on, it says VA's contracts don't include fittings for eyeglasses, but they could, but they don't. And I've heard in the time I've been sitting here that you all want flexibility. You don't want Congress to tell you how to do this because we're not flexible, and you want to have flexibility. But I'm not seeing flexibility. What I'm seeing is defensiveness of the way it's already done. And what we're asking for is better service for our veterans. I'll give you a second to respond, and then I've got another question.
Thank you for raising that, and thank you to, I think a few committee members had raised that issue was happening to us. So the reason why we don't support the legislation as written is that for us to be able to resolve long-term, what I think the issue is that you've raised, it's a contractual matter. It's not a matter of it needing to be codified as a medical service, and we absolutely do consider eyeglass fittings as part of the veterans benefits package. Now, the specific issue that I think you're raising, which is that we did have veterans that were having to drive significant distances, particularly in places like Utah, to be able to get their fittings. We're committed to being able to provide low-cost or no-cost eye care to veterans. And so the way this process has worked historically is a veteran would get their eye exam through a vision provider within VA, or if they're eligible for community care, they would get that through the community. But we have a very competitively priced contract or set of contracts that allows us to procure the actual glasses. So we do that part in VA. So that's created a gap on the part at the end, which is where they get the fitting. We have addressed this in the short term and are working on the long-term fix to that. There's a few different ways we can do that. In the short term, we've made a modification to our standardized episode of care. There's a few of them for vision care, so that we are now able to pay for that through our community care network contracts. In the long term, it could make sense to do that through those contracts. It could also make sense to bundle it with the glasses through a different contract. So we're carefully weighing that right now.
Okay, so I'm going to point out one more thing that was in the VA's response to this. One of the things we ask for in the bill is a report back from the VA within 180 days of what you're doing to respond to this. And it says VA would likely have nothing to report within 180 days of enactment because it would still be engaged in the rulemaking process, which could easily take longer than 2 years to complete. So I just want to point out one more time the irony that you're sitting here saying, don't legislate how we do things because we're flexible and we want to have that flexibility. But you're also saying we can't report back in 180 days because it takes us 2 years to go through a rulemaking process. Work with me, work with my staff. I want a solution to this problem more than I want to have a fight with the VA. But we've got to do better for our veterans. We've got to, we've got to design this in a way that veterans are getting the care they need instead of opting out of care because it's so inconvenient and so expensive for them to get it. Thank you. With that, I yield back.
Thank you very much, Representative Malloy. I now recognize myself for 5 minutes for questions. Ms. Peabody, do you think veterans should have agency in their health care choices? Should the veteran or the government decide what type of health care is best for them?
Thank you for that question. Yes.
I recently spoke with a veteran who was told by the VA he'd have to wait 3 months for an in-person primary care appointment, but could be seen by telehealth in 2 weeks. The veteran hadn't been to the doctors in years and wanted to be seen in person, but couldn't wait 3 months. Your testimony suggests that this individual shouldn't be eligible for community care. Is that correct, or am I misinterpreting what you said?
I'm happy to take that question. So in that case, we would want to make sure that we're not unduly delaying that veteran's care, understanding that if he or she has not been in for care, you're right, Dr. Miller Meeks, there could be some issues there. So we would want to have the conversation with a veteran. Often we find that, the information is delivered and perhaps there wasn't bidirectional communication. So in that case, we would love to make sure we're doing what we need to do for that veteran. If that's an actual patient.
It's an actual patient, actual story.
If you could pass that on to us, we'd like
So
to help.
and thank you, Dr. Scavella. The access to care wait times that you mentioned earlier, Ms. Peabody, do you know if that is in-person care only or if that is combined in-person care with telehealth, which are vastly different and addresses this question I had earlier?
I would like to take that for the record. Fair question.
Okay, so if you can get back to us exactly the wait times on in-person visits, for requests for in-person visits, exactly the wait times for telehealth visits, and the combination, those two should be separated. I'm just going to mention, because I'm an ophthalmologist, I'm going to just follow up on Representative Malloy's question. If the VA wanted to handle this issue and it were a contractual issue, there are ways to do that, i.e., the veteran goes, gets their eye exam at a VA facility. In this case, it's a 500-mile round trip for the veteran in Ms. Malloy's district. They get their eye exam, they get their glasses, they have the prescription, they get their glasses through the contract that you have to get glasses at an attractive price for the VA and for the taxpayer. We appreciate that. However, why couldn't the veteran be given the option that in order to get we can mail you your glasses, and then you can take them to somebody in the local community privately and pay for them to be fitted or adjusted? And especially our veterans have bifocals, so I can see why you want them to get fitted for their glasses, or you can come back to the VA. Either or, it's going to be less expensive for the VA if you're paying for travel for 500 miles round trip and a hotel for an overnight stay. So there's out-of-the-box thinking that you could have come to us, to Congress, to Representative Malloy, and said, let's help you fix this problem, which it doesn't seem like you're intent on doing. So both as a veteran and as a doctor, to me, I find that there are multiple barriers put up to receiving community care. And quite frankly, veterans in our military strength, veterans go back to communities. They don't go back to VAs. They don't go back to military hospitals. They go back to a community. And that community may be miles and miles away from a VA facility. The care may be excellent. You may have high approval ratings for the care that you receive. But if you can't get that care, if it's 3 months to wait, and Dr. Scavella, if an individual had to wait 3 months for a primary care appointment, please tell me, and I've trained residents at VA hospitals, how in the world does that impact your training of residents? You're seeing the same number of patients. A 3-month wait only impacts the veteran. It doesn't impact the residency training program, does it? How does that?
I agree with you. And so I think in that case, we would have to look at what we were offering that veteran to make sure we were being, doing the appropriate thing. Oftentimes we'll have a discussion and there's a telehealth option available and a face-to-face option. And if the telehealth availability is sooner, often patients will accept that as an option as opposed to waiting. And the reason why we have that mismatch is not that we have folks opting to provide telehealth, but often we are level setting because of our shortage of physicians across the country. So there may be a clinician in 3 states over that's providing that care to that veteran, and they're able to provide it because they've got the availability. And
but that shouldn't, excuse me, that should not be a denial of community care because you can get the care 3 states away.
Correct.
Which leads to the frustration. I did a bill as a state senator for schools as a site of service for behavioral health and mental health for children, but they had to have a face-to-face visit prior to having a virtual site of service off. So I can see the frustration veterans have if the response is, 3 months for an in-person, but we can get you in telehealth. If the veteran doesn't want telehealth, or if he doesn't feel that's appropriate, he or she doesn't feel that's appropriate, then they should be offered the community care, and the barrier should not be put up to that. And I'm over my time, and since I was tapping everybody else out, I want to hold myself to the same standard. So thank you all very much. I appreciate your coming. On behalf of the subcommittee, I want to thank you for your testimony and joining us here today. You're now excused, and we'll wait for a moment as the second panel comes to the witness table. I had all kinds of questions. Welcome, everyone, and thank you for your participation today. On our second panel, we have Mr. Cole Lyle, Director of Veterans Affairs and Rehabilitation for the American Legion, Mr. Darren Selnick, Senior Veterans Affairs Advisor, Mr. Patrick Murray, Director of National Legislative Service for Veterans of Foreign Wars, Ms. M.J. Burke, First Executive Vice President of the National Veterans Affairs Council for the American Federation of Government Employees. Mr. Lyle, you are now recognized for 5 minutes.
Well, thank you, Chairwoman Miller Meeks, Ranking Member Brownlee, distinguished members of the subcommittee. Though I have testified for this body before, it is now my honor to do so on behalf of National Commander James LeCourcier and the American Legion, the country's largest veteran service organization. Comprised of over 1.6 million dues-paying members, the Legion is, and always has been, guided by a strong and vocal membership, shaping the national conversation on important issues. We look forward to working with this committee and others in Congress to continue that proud tradition. As an end user of VA for healthcare and benefits myself, I understand the successes and frustrations many Legionnaires feel when trying to obtain an appointment, navigate community care, and feel empowered to make their own decisions. Congressional intent of the Choice and Mission Acts was to strengthen the VHA's direct care system while supplementing it with an important relief valve of community providers to ensure a scandal like Phoenix never happened again. However, despite large increases in VA full-time employees, the inability of VA to meet access standards, and the disregard for the Air Commission, this has led to a skyrocketing community care budget, which has naturally resulted in debates on balancing funding with the VA's direct care system and adherence to eligibility requirements, which largely encompass the reasons we're here today. Congress must address the infrastructure problem in the 119th Congress and ensure the VA direct care system is strengthened, as was also the intent of Mission. But in the absence of current VA capacity, we must keep the individual veteran as our North Star. In the past few years, there have been credible reports of VA administrators overruling decisions by providers and patients to keep veterans in the system, in some cases cutting off care entirely. I've personally dealt with trying to use DC VA and been quoted long wait times only to get a faster appointment after I asked to be given the option to use community care. The American Legion strongly supports keeping the VHA as a coordinator of care for veterans, which is why we oppose HRs 214, 3176, and 5287 as presently drafted, all of which would take a veteran's VA provider and the veteran out of the equation entirely. However, if the VA cannot provide veterans with the care they need when they need it, community providers are the only realistic solution in the best interest of the individual veteran. This is why we support the Complete the Mission Act of 2024, which, amongst other important changes to scheduling, would codify access standards and ensure veterans get the care they need in consultation with their VA provider. Together, they can assess what is in the best medical interest of the veteran and maintain autonomy in their own health care. Another bill being considered is H.R. 9924, the What Works for Preventing Veteran Suicide Act. Amongst the highest profile suicide prevention programs administered by the VA in recent years is the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program, which partners with nonprofit organizations to facilitate upstream approaches to suicide. Fox grants have allowed organizations to coordinate initiatives related to post-traumatic growth, peer support, and cultural faith-based programs. This upstream approach aligns with the American Legion's Be the One campaign and Buddy Check program, and we strongly support any effort by this committee to address the veteran suicide epidemic. But we also recognize Congress's duty to ensure taxpayer dollars are going to effective programs and organizations. The American Legion supports H.R. 9924, which would establish standards for clear and measurable objectives to help evaluate the effectiveness of programs like Fox and the creation of a standardized methodology for future initiatives. Also being discussed are H.R.s 6333 and 8481, the first mandating the VA pay for all emergency care expenses, not just for those without insurance. The second changes the VA's overly burdensome requirement that veterans notify the VA within 72 hours from the start of care to 72 hours from discharge. It is entirely possible that a veteran could be denied a claim because they were in a coma after a car accident and weren't able to reach the VA within the required time frame. Both bills help ensure a veteran's financial and mental health are not affected by the unintended consequences of bureaucratic requirements. Lastly, H.R. 8347 directs the VA to conduct a study on menopause care furnished by the VA. Women veterans are the largest growing demographic group of veterans, and they often face unique challenges that necessitate gender-specific care. The American Legion has authored numerous articles about the factors that impact women's health, including menopause, and it remains a priority for us. We support this bill as currently drafted. Chairwoman Miller Meeks, Ranking Member Brownlee, this concludes the Legion's testimony. We have submitted a longer written statement for the record, and I'm happy to answer any questions related to the written statement or my shortened testimony today. Thank you.
Thank you, Mr. Lyle. Mr. Selnick, you're now recognized for 5 minutes.
Thank you, Chairwoman Miller Meeks, Ranking Member Brownlee, and members of the committee. I appreciate the opportunity to testify at today's hearing on 3 critical bills: Veterans True Choice Act, Veterans Healthcare Freedom Act, and Complete the Mission Act. These bills embody a promise to our veterans to provide timely, quality, and convenient healthcare options that honor their service and sacrifice. I speak today from both professional experience and personal conviction. My expertise in this subject comes from being a member on the VA Commission on Care, working at the VA and the White House Domestic Policy Council in helping to create, negotiate, and implement the Mission Act. I believe veterans deserve nothing less than excellent care, whether delivered at VA facilities or through community care providers. VA care should be a choice, not an obligation. Community care should be a high-quality alternative, not a compromise. Today, the VA healthcare system is failing too many veterans. This failure is due to a system that prioritizes institutional preservation over the well-being of veterans. No one wants a failed Veterans Health Administration. Instead, we want to make VHA great again for veterans. However, the current state of VA healthcare hurts veterans. A few examples from media headlines. Cancer patient dies after delayed treatment at Fayetteville VA. Local veterans furious, chiropractic care cut off by Hampton VA. Probe into VA facility uncovers orgy. Some personal examples from veterans have been illegally denied community care. A blind veteran in Louisiana who lives an hour from the VA Medical Center. A veteran in Arkansas who needed immediate placement in a SUD residential treatment program, but instead was offered an Uber ride by VA to a homeless shelter, despite a community provider having a bed available. We know that VA is not following the Mission Act due to FOIA documents. They show failing to follow community care eligibility requirements and denying community care, canceling and rescheduling of appointments without agreement of the veteran, actively dissuading veterans not to use community care. Other evidence includes the VA Red Team report, recommended repatriating veterans into VA facilities and cutting community care for emergency care, mental health, oncology, and other specialties. The VISN 16 Referral Coordination Initiative Plan incentivizes VISN directors to increase their direct care while decreasing community care. Critics say community care is too expensive and that outcomes are better at the VA. The facts say differently. 40% of veterans' care is community care. Yet that is only about 26% of the VHA budget, saving VA money. VA survey of veterans in 2022 found overall satisfaction with community care is at 83%, while overall satisfaction with VA hospitals is only 69%. A 2023 JAMA study reported that VA enrollees with private coverage were most likely to report being in good health, while VA was most likely to report poor health. These 3 bills will simply provide veterans with healthcare choice of either VA facilities or community care. Veterans True Choice Act is predicated on the simple premise that if service-connected disabled veterans are not happy with their VA care, they can instead select other proven federal healthcare programs. In this case, either TRICARE Select or TRICARE for Life, which is the same healthcare choices retired military have. Veterans must choose either the VA or the applicable TRICARE program. DOD will receive reimbursement from the VA for veterans who opt in for TRICARE Select or TRICARE for Life. This is a great step forward for veterans. Veterans Healthcare Freedom Act will streamline access to care and implement recommendation number 1 from the Bipartisan Commission on Care, creating a fully integrated healthcare system where veterans can choose the healthcare provider that best meets their needs, either at a VA facility or community care. This recommendation was approved in 2016 by both Secretary McDonald and President Obama. It improves access to care and requires the VA to give veterans information about eligibility, cost sharing, treatments, and providers. Veterans will now have full choice and control over their healthcare decisions. Complete the Mission Act. This bill is necessary due to VA not following the Mission Act and negating congressional intent. It would protect veterans' healthcare choices from bureaucratic meddling and improve veterans' access to their preferred care. It applies access standards, requires VA to inform veterans of the community care eligibility, ensures accurate wait times, and returns inpatient mental health referrals to the existing access standards. Veterans will once again have confidence the VA healthcare system works for the veteran and not against them. In conclusion, veterans' healthcare is a moral imperative. It is critical that no matter how good or how bad VA healthcare is, veterans can have the choice of accessing the healthcare that works best for them. These 3 bills ensure that. As VA goes forward, it must change its culture in healthcare to become veteran-centric. As General Omar Bradley said, we are dealing with veterans, not procedures, with their problems, not ours. Look forward to working with the chairwoman, ranking member, and all members of this subcommittee on health to achieve our shared commitment. I'm prepared to answer any questions. Thank you.
Thank you, Mr. Selnick. Mr. Murray, you're now recognized for 5 minutes.
Thank you, Chairwoman Miller Meeks, Ranking Member Brownlee. Thank you for the opportunity to provide our remarks at this hearing today. Veteran health care is an incredibly important issue, and as a current user of both VA and DOD's healthcare system, it's my privilege to speak on this topic today. A recent health survey by the VFW, which was closed just last week, reveals that our respondents prefer using VA facilities for their healthcare needs. 3,100 veterans responded to this survey, which showed overwhelming support for VA to remain the primary deliverer of care for veterans. 86% of respondents said they were enrolled in VA healthcare, and 85% of those said they would recommend that. Lawmakers must prioritize creating a robust healthcare framework for our veterans, ensuring VA has the necessary resources to effectively support its mission and deliver the care that veterans have earned. We shared some initial numbers with the committee staff, and we'll share the full feedback once it's reviewed and analyzed. The VFW generally supports the Complete the Mission Act of 2024, and we have some suggestions and feedback to strengthen this proposal. Primarily, we believe any bill that builds upon the Mission Act must include a revamped Air Commission, like the original bill from 2018. The flawed rollout of the market assessments by VA, political infighting among members of Congress, and the inability to appoint commissioners to perform their jobs doomed the AIR process and ultimately led to it being dissolved. This was not helpful to veterans and the care they receive at VA. An infrastructure review and future plan must be enacted and carried out to ensure VA can execute its mission to deliver timely, comprehensive care to veterans through a modern infrastructure that seamlessly integrates direct, contract, and community care now and in the future. The Mission Act of 2018, including many provisions that were anticipated to help veterans, caregivers, and survivors. It transformed the Veteran Choice Program into the community care network we see today. However, community care is plagued with too many problems that need thoughtful solutions. Unfortunately, it seems whenever community care is discussed, it's in polarizing terms of either preventing wholesale privatization or opening full choice to the community. Neither is realistic, nor what veterans who are actually using VA are asking for. Our veterans who use VA prefer to stay in the VA system and tell us they typically want more VA care closer to home and easier to access. Care in the community is necessary for some veterans, but if given the choice, our members routinely tell us they prefer VA direct care. We believe some of that sentiment is driven by negative experiences within the community care process. We must fix these issues because our veterans have earned quality care regardless of who provides it. When used properly, community care can save lives and improve the health outcomes for countless veterans. But when problems arise, it can drive people away from the care they've earned. The VFW has consistently reinforced to VA that its greatest cost for care in the community is uncoordinated emergency room care. We have also called on VA to lean on its third-party administrators to ensure consistent delivery of community care to veterans who are eligible. When 23 VISNs interpret the Mission Act in 23 different ways, veterans are overlooked. just as the VA Inspector General pointed out earlier this year in Buffalo, New York. DoD has been able to make this work through its community care networks, which means that when veterans seek to navigate VA care for the first time, they rightfully expect a similar experience to navigating care in the military. What is jarring is that DoD's networks are administered by some of the same vendors. However, VA refuses to similarly integrate these vendors to allow for seamless care for veterans. Nothing prevents VA from using the tools at its disposal to deliver predictable and timely care through its direct system and its community care providers. We think that it's sad that we have to have the discussion on completing the mission when we believe that Congress intended for VA to implement this program the correct way the first time. Chairwoman Miller Meeks, Ranking Member Brownlee, thank you for the opportunity to provide our remarks to this hearing today. I'm prepared to answer any questions you may have.
Thank you, Mr. Burry. Ms. Burke, you're now recognized for 5 minutes.
Chair Miller Meeks, Ranking Member Brownlee, thank you for inviting AFGE to testify at today's hearing. I am MJ Burke, First Executive Vice President of the National VA Council, proudly representing 306,000 VA workers. I am also a physical therapist at the Indianapolis VA. I came to VA to practice in a setting where decisions are about patient care guided by clinical evidence, not a corporate balance sheet. The VA is at a tipping point. 4 of the bills that the committee will consider today will radically accelerate privatization, ultimately leading to veterans to lose their choice of high-quality integrated care delivery that VA offers. Our members feel that the efforts of rapid privatization in the form of unpredictable staffing and closures of inpatient operating beds related to widespread VA facility budget problems, which make it difficult to provide veterans with the care they deserve. Referrals to private care have been rising between 15% to 20% a year, which is clearly an unsustainable trend for the direct care system. Proponents of privatization say they are doing this in the name of choice. However, approximately 92% of veterans have other options for health insurance, the majority of employer-sponsored coverage, or access to the private health care plans through Medicare. Attempts to privatize the VA feel like they're too rooted in ideological opposition to government-run health care and a desire to remove this option for those who want it or need to use it. If we want VA to continue, we must reverse privatization rather than accelerate it. For this reason, AFGE opposes the following concerns about the following bills. H.R. 3176 creates a 3-year pilot program allowing veterans to bypass VA authorization to meet access standards. No healthcare system could survive if it's forced to pay for whatever out-of-network provider a member wishes to see and still provide services to its enrollees. This will lead to service closures and create more limited options for veterans who wish to have their care internally at VA. H.R. 5287, this would establish HSAs funded by the VA that veterans could use for private health care. Veterans electing to use these HSAs would be barred from accessing VA healthcare services. As a result, AFG opposes this bill. Complete the Mission Act, Section 101, codifies the current access standards, which unnecessarily promotes privatization. The standards prohibit also the Secretary from counting VA telehealth and determine whether VA meets wait times and drive times access standards. AFGE believes that access and quality standards should be equalized for VA and non-VA care. AFGE also believes the one-size-fits-all access standards are problematic for a variety of clinical presentations. Section 103, AFGE opposes comprehensive ban on VA's authority to review community care referrals. The definition of best medical interest should align with clinical evidence standards. We also believe that VA should update its training to make sure that BMI standards are implemented appropriately. Section 203, this section creates a 3-year pilot program in which 5 locations where VA would not authorize care for outpatient mental health and substance use services. AFGE opposes this provision as it would circumvent VA's ability to coordinate care. H.R. 214 would allow veterans to choose TRICARE and require VA to pay for it. Veterans would not be allowed to use VHA facilities. This would starve VA financially. AFGE opposes H.R. 214. H.R. 8481, this would change the 72-hour rule with notification only after ER services were provided. with studies showing that private emergency care is often lower quality, and given current expenses, this would be unsustainable. AFGE therefore opposes this bill. We support the following bills: H.R. 9924. This efforts create standards for grant programs regarding suicide. H.R. 633. We support capping out-of-pocket expenses for veterans who receive emergency care. However, we must build at the same time and improve upon efforts to reduce unnecessary emergency care costs. AFGE supports legislation under which Secretary of VA pays for medical education of an officer in the public health services at the respective university. We thank you for the opportunity to present its views about these bills, and we look forward to your questions.
Thank you very much, Ms. Burke, and I thank all of you for your testimony and your thoughtful input. Ranking Member Brownlee, you're now recognized for 5 minutes for questions.
Thank you, Madam Chair. Mr. Murray, good to see you. You gave a lot of statistics around having surveyed your veterans and why they like, or a large percentage like getting their health care from the VA. Can you point out why they like it? Is it because it is, the physicians, people there understand them better than going out into the community? Are there elements in which I believe that there are elements that the VA provides that just are not provided in the community? And I agree with you. I don't think we can look at these two entities as one or the other. We have to look at it as a delivery of healthcare services to our veterans, and I don't think the VA can do it all by themselves. Women veterans, as an example, if they're pregnant, the only choice they have is community care. So, I agree with you on that, but I'm interested to know why veterans like their health care in the VA.
So we didn't ask that in the survey, but we have heard before that ideally VA can be kind of a one-stop shop. You can go to your primary care, you can go do podiatry, you can go get your x-rays, your blood work done, and then stop by the pharmacy on the way out. The idea that you can get all your care, if you can manage to schedule it all in one day, that is a tall task to be able to do. But if you can do that, that's ideal. You can't do that elsewhere in the United States. Private healthcare does not exist that way. Yeah. So that's something that is incredibly important. You are right, though, about women veterans. My wife and my little sister both use VA, and both going through pregnancies, were immediately sent to the community. That's something that we need to kind of embrace. When VA can't do it, don't try to hold on to it. I also use the DOD system. DOD does not view me going to the community as a threat, the same way that VA sometimes does, that they're trying to hold on to my care at VA. DOD does not do that. I am a retiree, so admittedly, they may view me as somewhat of a burden to the system, but me going to the community is not a big deal at the DOD system, but it is at VA. We need to kind of break that mentality and use it to support. VA can't do it all themselves. They never have been able to. The Choice Act and the Mission Act made sure that VA should know they need to lean on the community where necessary.
Thank you. Thank you very much. And Ms. Burke, thank you for being here. It's very good to see you, and thank you for what you do and providing a voice for so many VA employees. Really appreciate that. So from the perspective of frontline providers at VA, the Veterans Choice Act of 2014 and the VA Mission Act of 2018, talk about how that has impacted frontline employees. Has it affected the provisions of services at VA medical, delivery of healthcare services at VA medical facilities?
Thank you, Congressman Brownlee, for the question. I think, generally speaking, having, we have like 14 pages of scheduling rules, and so that the complexity of the rules is quite confusing, number one. But as time goes by, when you're looking at 15 to 20% increases over and over, the effect of that really is it kind of erodes the internal process of what VA is delivering. And so I don't think we are never going to be in the situation of opposing giving care when it needs it. Since I've been at the VA for 30 years, we've always done that. But I think really we need to kind of stand back and think about how we're going to fund the VA, what we're going to fund, when we're going to fund it, because I feel like this is unsustainable. We're on a path of unsustainable situations. But you know, there isn't one rule that fits all, I think, in this case scenario. And I think you have to look at specialty care a little bit different than you look at, and things that people need, like dialysis, cancer care.
Yeah. So I don't have much time, so I want to get another question in here. So, you know, this whole, I think we're all agreeing on, you know, that community care has increased over time. And I'm interested to know what the impacts are on frontline employees, their morale, their recruitment, retention, all of that. Is that, can you talk a little bit in 10 seconds
Yeah,
about the
sure.
impact?
Ultimately, when I see 12 patients a day, that looks a lot different than when I see potentially, you know, if we had access standards and a cap of money, 20 patients or 25. I'm being extreme right now, but as you can see, that's going to create burnout and so forth.
Thank you. I yield back.
And thank you. The chair now recognizes Representative Malloy for 5 minutes for any questions she may have.
Thank you, Madam Chairwoman. I will be quick. I just have a couple of questions. Mr. Lyle, thank you for your support of the C Act. I'm just curious, are there other similar gaps in community care networks that the American Legion is aware of and would like us to be aware of, the way we have this gap in optometry where somebody can go get an eye exam but not get fitted for eyeglasses?
Well, thank you for the question, Congresswoman. I think you know, small, I wouldn't say small, but gaps like the optometry gap are, you know, I think the minority of cases, but the most significant gap, obviously, that we're here to talk about today is just generally speaking the codification of the access standards, because the VA, you know, has shown in the past few years their willingness to not adhere to the regulatory guidelines. I mean, honestly, with less than 50% of veterans enrolled in VA healthcare, and then I think 4.5 million veterans using it on a routine basis, we're talking about a population of people that obviously for coordination of care purposes and for you know, their preference of using VA care is important, but when they need that care in the community, as has been noted, community care is VA care, and that's the biggest gap that we need to address.
Thank you. Mr. Murray, I have a kind of similar question for you. I was listening to your stats. I thought that was really interesting. A lot of the veterans prefer to have VA care, and I have a lot of rural areas in my district that are a long way from VA care. Do you have anything you want me to know about how, as a lawmaker, I can balance that need for veterans to be able to have the care they want and to make sure that veterans can get care when they're not near a VA?
Sure. So I don't have Utah information ready off the top of my head, but we do have New Hampshire. Veterans are in a similar situation where every single veteran in New Hampshire is immediately eligible for community care based on drive time standards alone. And our members are asking to not have to go to Boston, not have to go to Vermont. They want something in the state. So, you know, I don't know the exact geography of where, you know, what clinics could be put in Utah, but the Air Commission is something that provided recommendations, not just for building, we're not saying more VA hospitals, right? That may be an antiquated thing of the past. It could be more clinics, it could be more purchased care, it could be more leased care. There are ways that we provide this care, and the market assessments provided a roadmap for how to do that, where to utilize the community partners, where to purchase care, where to build care. So that's something that in Utah we could really look towards. I don't know exactly what it is off the top. I might have to go back and look at that vision, but that's something I'd recommend.
All right, thank you. With that, Madam Chairwoman, I yield back.
Thank you, Representative Malloy. The chair now recognizes Representative Budzinski for 5 minutes.
Thank you so much, Madam Chair. Good afternoon, everyone. Thank you to the witnesses for being here today to share your thoughts on improving VA care for our nation's veterans. I also appreciate the efforts of my colleagues for offering legislation that builds on suicide prevention efforts, bolsters our VA medical workforce, and develops unique care for women veterans. That being said, I am deeply concerned by some of the legislation offered today that I think will open the door to privatizing VA care. According to a Red Team executive roundtable report released earlier this year, an alarming rate of veterans are being pushed to community care providers, threatening to erode VA's direct care system. I believe some of this legislation will only push us closer to that breaking point. My first question is for Ms. Burke. The Complete the Mission Act, H.R. 10267, would codify existing community care access standards. Can you explain why this could potentially be problematic?
Thank you, Congresswoman, for the question. What the codification does is basically lock in the rules for access, and consequently, it doesn't give the agency flexibility in determining really access metrics. It's not that we don't need access metrics for some stop codes or clinical provisions. It's just making a great blanket over access, drive time. Is that germane to clinical outcomes? Is that germane to the cost of delivering those outcomes? And is that germane to patient satisfaction? Those are kind of the three tenets I look at, and I think the VA should be looking at, and quite frankly, maybe even Congress should be looking at, in order to determine are the taxpayers and the veterans getting their bang of the buck.
Okay, so more flexibility is what you're saying that would
Right.
be helpful as you're looking at those metrics. And then could you also answer, in the absence of one-size-fits-all access standards, how should VA, with oversight from Congress, manage access to community care network?
Thank you again for the question. I think the way I kind of think of it is really driving home best medical interests, specifically in the fact of one size does not fit all. So, like for an example, even though it may be politically charged to say a veteran may want a total knee replacement, but he may be morbidly obese, his sugars may be uncontrolled, and he may need assistance even getting 10 feet of walking. That person may not meet the definition of best medical interest for surgery. But then we have other cases, for example, where a veteran, spinal stenosis, a diagnosis that's very common among our veteran population, a person has failed mat exercises, he's still having intermittent claudication, he or she, and then at the end of the day, you know, Indianapolis may not have water or pool therapy. That may be a situation, if the person's open to it before having surgery or before having other interventions, that we do a trial on those things. So I think that's where we should be focusing on, what evidence is out there for what diagnosis is, and specifically, you know, what's the cost of that and patient satisfaction.
Can I also ask, Ms. Burke, from your perspective, how does the quality of care provided by VA-employed healthcare professionals compare to that of private sector providers when it comes to veteran-specific needs?
Thanks for the question. I think this is one of the things I think is not very well known, that I wish was a topic for future generations of hearings. I think the research department, specifically in VA, is excellent. They did a recent systematic review of over 2,000 studies. I think you heard it mentioned in the prior panel's testimony, as well as the VFW's testimony, and generally found that VA care is as good, or if not better, in many of those studies. Now, not all of it wasn't necessarily conclusive, but the very things that people suffer from, CHF, lung screenings, a variety of things, VA does better. And so we want to make sure that when we are going out of VA, that it's going to be faster and as same quality as we're delivering internally.
Okay, thank you, and I'll yield back.
Thank you.
Thank you very much, Representative Budinsky. I now recognize myself for 5 minutes. Very quickly, will all four of you tell me why the Mission Act was put into law, Mr. Lyle? Brief, please.
Essentially to give veterans access to a community provider if the VA was unable to meet certain times.
Mr. Selnick?
Yes, it was to go ahead and make sure that we modernize the VA healthcare system, and we modeled it after the TRICARE Prime system, so that veterans would always have choice and always have a backstop, and would always have the ability to get access to care.
Mr. Murray?
Because VA cannot, they have not been able to, they never have been able to, and they never will be able to provide 100% of the care to 100% of the veterans 100% of the time.
Ms. Burke?
Yes, and in the wake of 2014, the veterans did not trust VA in delivering their care, and there was somewhat in media good reasons for that. I think therefore, as a result of that, the agency put in drive time and wait time requirements as a result.
So let me just say I'm a 24-year Army veteran. My husband's a 30-year Army veteran. 6 of the 8 children in my family served in the military, as did my father, who was retired in the military and had care at a military hospital. The reason why the Mission Act was put into place was because veterans were dying waiting for care. It is that simple. Your care may be the most excellent in the world, but if a veteran can't get in there to get care, it doesn't matter. Community care exists because veterans were dying waiting to get into care. This should be a collaboration. Mr. Stelnick, how does H.R. 10,267 protect a veteran's choice in where they receive health care?
Codification of the access standards are very important. When we created the access standards, the reason we didn't put it in the original legislation is because we need to go ahead and benchmark and find out what would work. We borrowed from we did all the studies just like we needed to, commercial, Medicare, et cetera, DOD. And the DOD access standards, and I'm retired military, I go to Camp Pendleton, is tougher access standards than the VA. So we needed to codify it. We put in the requirement to go ahead and check it out. It's been tested out, it's been proven out. VA's not been following it. Veterans need certainty that these access standards will stay, and the current administration has indicated they want to change it to eliminate it. And that's why we need codification number one. In terms of best medical interest, VA has overturned its own doctors on best medical interest.
Mr. Lowell, given the critical role community care plays in addressing veterans' health care needs, how can VA further integrate community care into the VA system?
Well, I think there's thank you for the question, Chairwoman. I think there's a number of ways. I think the largest and most important way is streamlining the scheduling of community care and ensuring that if a veteran gets referred to community care, they can get to choose the time and place that they access care in the community.
And Mr. Murray, I think you had some input on that. I can see you're dying to answer this question, or not dying, but you're excited to answer this question.
I think Mr. Lyle hit on one of them, scheduling. Part of the Complete the Mission Act is directing VA to work with its third-party administrators to develop an interactive scheduling system. We suggest they buy it to whatever extent possible. There are private platforms that they can use. VA is piloting right now with one of them. We want to see that happen. VA has been historically terrible at doing their own IT solutions. We should not, please don't direct them to try that again. They're not good at it.
You actually mentioned what the active duty military is doing, or what military is doing with their retirees in community care. Ms. Burke, you believe that codifying the access standards in the Complete the Mission Act unnecessarily promotes, your words, privatization. Please tell me how codifying a standard time frame in which VA should provide care privatizes the system.
Currently, the way the PACT Act and the way the budget mechanics are, we have 2 years in the rear of funding prior to going to when the unique is vested. So, it makes it very difficult for what we hear from managers to even budget forecast some of the system as bifurcated as it is. To see like an increase of 30% of uniques coming into us for the PACT Act. At the same time, they're looking out in the horizon saying, okay, now we have to segregate out these patients for veterans care, and at the same time, we don't have the flexibility necessarily to increase for those veterans that may want to see internally to VA.
Thank you. It sounds like a budgeting problem rather than privatization, which is often used as an inflammatory word. Thank you so much for our witnesses for being here today. Ranking Member Brownlee, would you like to make any closing remarks?
I think there are several good bills in this package, and I think we need to, the other bills, I'm not discounting, but I still think that we need more time to go over this issue and dig deeper in you know, community care, direct care from the VA, what the right balance is in terms of moving forward. I think it's what veterans want generally. I mean, from so many different sources, we always hear that veterans prefer VA health care if they can get it. Sometimes they can't get it. Rural areas, sometimes they can't get it. So we've got to have both entities working together with each other to provide high quality health care to veterans, which I think we all agree is the road we all want to travel down. But I think we need to spend more time digging a little deeper to find the right balance. With that, I will yield.
Thank you very much, Ranking Member Brownlee. First and foremost, let me just say that having worked in the VA hospital as a nurse and a physician, that I do think the majority of our VA hospitals give excellent care, and I think they're dedicated to taking care of veterans. I think the work that they can do in prosthetics and in rehabilitation and coordination of a variety of different aspects of care can be very beneficial, and to Mr. Murray's point, a one-stop shop. Let me also say that I take umbrage what I've heard and hear today about trying to privatize or privatization. I think the word is used to be inflammatory and to scare veterans. What veterans want most is just to get the care that they're eligible to get, and to get it in a timely fashion. And I think to address the needs of those veterans, to build more VA facilities, all of that comes at a cost. And that too reduces the cost and the budgeting to the VA as well. As a veteran myself, I may or may not be eligible for care at the VA. But because I'm not a combat-related veteran, even though I'm a Vietnam-era veteran, I don't choose to get care at the VA. Some veterans get care at the VA because they think it's the excellent care. Some veterans get care at the VA because they like being in a military facility with veterans. They like that unit aspect of getting care at the VA. Some veterans don't want to get care at the VA. They don't trust the VA, and I've heard that. Some veterans get care at the VA because they don't want to pay a copay or a deductible, and they don't have to pay for their prescriptions. It may not have anything to do with the quality of care. There's a whole host of reasons why a veteran may choose to get care at the VA or not at the VA. But I think what's most important in what you're hearing from us is that we hear from our constituents a variety of things, and we want to make sure that we can address veterans getting the care to which they have paid a significant price and sacrifice to receive, and that is, as a country, our contractual obligation to those veterans. So I thank our witnesses from the VA, Ms. Peabody and Dr. Scavella, for being here today. I thank all of our witnesses who have been here on behalf of the committee. I look forward to working with all of you to address the issues that are facing our veterans. The complete written statement for today's witnesses will be entered into the hearing record. I also want to say that we have two of our members of our health subcommittee that are departing, Olivia Naughton and Louise Mendoza. I want to thank them for their service to this subcommittee, thank them for all they've done for our veterans, all of the input they have taken from them, even when whistleblowers approached this committee about issues with the VA. So thank you very much, Olivia, and thank you, Louise. I ask unanimous consent. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Hearing no objections, so ordered. Let me also say, Merry Christmas, Happy New Year, and I will look forward to working with all of you in the new year. This hearing is now adjourned.